Can we start, sir?
I think let me introduce you. Okay. So we'll start.
Yeah.
Okay. So good afternoon, everybody. Welcome to yet another lecture from the Jaipur Surgical School. And today our guest speaker is going to be a very distinguished GI surgeon, Dr. Patta Radhakrishnan. It gives me a great pleasure to introduce him to you all. He is a consultant GI surgeon practicing at Chennai, and he has the honor and privilege of working with stalwarts like Professor Rangabasham, with whom he did his GI surgery, and thereafter worked as senior resident with Dr. Professor Nandi. So you can imagine how strong his basics must be. He did his UG studies from Jaipur and has a wide experience of practicing abroad as well. So now, without wasting much time, I hand over the podium to Dr. Patta Radhakrishnan, who is going to talk to us today on a very important topic of how to approach a patient with portal hypertension. Over to you, sir.
Thank you, Chetan, sir, for that kind introduction. And good evening. And in the next half an hour or so, I shall try to make you understand what exactly this portal hypertension means, the physiology of portal hypertension, and how to approach a patient with portal hypertension. I shall gently introduce the topic, and the most important part of this lecture will be to differentiate between cirrhotic portal hypertension and non-cirrhotic portal hypertension. This concept is a concept very pertinent to Indian subcontinent, which is not so much seen elsewhere. I will briefly touch upon the management protocols and the current protocol of management of patients with portal hypertension. I'll also comment on what sort of elective or emergency surgery do you perform in these patients, and if there are any non-surgical interventions one can undertake. Then, of course, the role of shunt surgery and transplantation, a word about Indian perspective, and then I shall summarize. Patients with portal hypertension come in three different scenarios. One scenario is the emergency ward where they come with massive gastrointestinal bleeding. Either it will be a massive hematemesis and sometimes hematemesis and melena combined, and they are sick and they require resuscitation and subsequent diagnosis and management. The second group are the ones who come to the OPD. They come with history of recurrent GI bleed, melena, over a period of time. Usually these are children or young adults, and then we need to investigate and also tackle them. The third group are the ones who are diagnosed as portal hypertension. They come with splenomegaly with or without hypersplenism, and the treatment protocol for them is slightly different. These are the three categories of patients with portal hypertension we tend to see in our clinical practice. Now, before I go into the depths of portal hypertension, I would like to make you understand that what exactly is portal hypertension. We all know systemic hypertension, which every other individual has and gets treatment. Portal hypertension is not that common. What is portal hypertension? You should understand that as compared to any other part of the body, like example, the upper limbs, the lower limb, the kidneys, they are supplied by arteries from the aorta, and the venous drainage is to either the inferior vena cava or superior vena cava. But the digestive system is different. The venous drainage to the digestive system is not straight to the inferior vena cava, but it will go through a complex system of veins called the portal venous system, and they'll enter the liver, and the blood that goes from the GI tract will get filtered in the liver, and from the hepatic veins it will go to the inferior vena cava. So effectively, all the blood that goes to the GI tract has to get filtered in the liver. So the venous system that drains the GI tract is called portal venous system. As you see here, the superior mesenteric vein, the splenic vein, the combined together form the portal vein and enter the liver. Now, this is a close view of the portal venous system, and we should understand that the normal pressure in the portal vein is anything up to 0 to 6 millimeter mercury, and if it increases due to some cause, either there is an obstruction in the portal vein or obstruction in the liver parenchyma or even obstruction in the hepatic vein, when there is a pressure buildup in the portal vein which crosses 10 millimeter mercury, that is called portal hypertension. So effectively, all patients with portal hypertension have an increased pressure in the portal venous system. This is how the portal vein looks like, and this is a patient with the Whipple's procedure, the stent in the pancreas, and that's how in real life a portal vein will look like, normal portal vein. Now, as I said earlier, the normal portal pressure is anything between 8 to 15 millimeter of mercury. And then the systemic venous pressure is anything up to 0 to 4 millimeter mercury. Anything more than 15 millimeter mercury in the portal venous system is termed portal hypertension. And then the portal venous system is different from the systemic venous system in that it does not have valves. Like the ones you see in the upper limb veins and also the saphenous vein, where there are valves, the blood flow can be in one direction. Whereas in the portal venous system, there are no valves, so that whatever pressure is in the portal vein, it will dissipate to the entire venous system, so much so that the spleen, which is at the end of the splenic vein, which has to take the pressure and enlarge and form what's called splenomegaly. So that is the basic difference between the venous system of the systemic veins as well as portal venous system. Now, when the pressure in the portal venous system increases, there are certain areas in the body where the systemic veins and the portal veins communicate in the form of a plexus, and that's where these veins open up, and they lead on to problems like esophageal varices at the lower end of esophagus. These are all the subepithelial bunch of veins of bulging because the portal pressure is increased. And even at the lower end of the esophagus and proximal stomach, these are the bunch of gastric varices, which also bulge, and the pressure in the portal venous system increases. And in the rectal area, there are rectal varices. They're all the manifestations of the bulging of the portal venous system and the portosystemic anastomosis. That is one area, lower end esophagus, that the short gastric veins, and these are the middle and inferior rectal veins. Now, it has always been understood by and large by non-GI surgery, non-medical GI people across the country and across the world is that if the patient has portal hypertension, it means to say the patient has cirrhosis of liver. In other words, these patients' hemoglobin is low, they have pancytopenia, their platelets are low, their coagulation is improper. So any patient with portal hypertension, either subjected for treatment of portal hypertension for any other treatment, the NS is invariably considered the patient's liver is damaged. But that is not the truth. As far as the Indian subcontinent is concerned, we have sizable number of patients who have non-cirrhotic causes of portal hypertension, where the liver is not damaged, is non-cirrhotic, but still they have portal hypertension. I'll tell you a little more about that in the slides that come. Now, there's one condition called non-cirrhotic portal fibrosis, which is very, very much an Indian condition. And in 1991, there was a conference in Chandigarh where all the non-cirrhotic portal fibrosis statistics across the country were summated, and it's been seen that 70% of the patients with portal hypertension in Sanjay Gandhi, Lucknow are cirrhotics, 10% are non-cirrhotic portal fibrosis, and 20% extrahepatic portal venous obstruction. But strangely, in the All Indian Medical Sciences, about 55% of the patients are extrahepatic portal venous obstruction, only 19% non-cirrhotic portal fibrosis. In Calcutta, 47% of the portal hypertension patients attending the Calcutta clinic are NCPF, and only 1% have non-extrahepatic portal venous obstruction. And strangely enough, in Chennai, 88% were cirrhotics. There was no data about NCPF. Still, there's no data. Whereas extrahepatic portal vein substitution is 12%. This is just to say that the sizable Indian population with portal hypertension have non-cirrhotic causes as well. So, what is the difference between cirrhotic and non-cirrhotic portal hypertension? If the patient is non-cirrhotic portal hypertension, the liver is just normal. The liver function tests are normal. There's no coagulopathy, there's no ascites, no hypoalbuminemia. This group of patients can undergo any type of surgery like any other normal patient, or even they can undergo portal hypertension surgery without having a risk of developing coagulopathy or bleeding or ascites or liver failure. Whereas to the right, you see cirrhotics whose liver is badly damaged and due to either alcohol or B or C viruses, their LFTs are abnormal. They have a high INR and coagulopathy. They have ascites and hypoalbuminemia. And if these patients, they are not fit for any non-liver surgery or even surgery on the portal venous system, because these are the people who eventually would, if they are fit enough and they fit into the criteria, would require liver transplantation than any other treatment. So understand, when a patient of portal hypertension comes to the clinic, we should find out whether these patients are non-cirrhotic or cirrhotic portal hypertension. As I said earlier, the only 5% of the portal hypertension patients in the rest of the world are non-cirrhotics, whereas in India, the numbers are quite high. See, as I said earlier, the ones with cirrhosis have all the signs of liver cell failure. So, clinical examination of this patient when they come with GI bleed, it's not very difficult to find out that they are cirrhotics with a damaged liver, or they are non-cirrhotics in the absence of any of these signs. And the liver is cirrhotic, the portal pressure is high, they develop varices, they develop ascites, and also they develop encephalopathy. Whereas a condition called extrahepatic portal venous obstruction we see in younger individuals, children basically, have a thrombosed portal vein, either due to umbilical sepsis during childhood, because a certain percentage of patients those days, they used to have their umbilicus cut with an unclean sickle at the time of delivery, and that used to lead to umbilical sepsis, and that used to lead to portal vein thrombosis. A few other children who develop diarrhea in their childhood, they have hemoconcentration, and they also tend to develop portal vein thrombosis. And some people with appendicular dyspepsia also have portal pyemia and portal. And these people's livers are normal, but they develop portal hypertension. And the portal vein thrombosis will eventually lead to what's called portal cavernoma. As you see in this diagram, the portal vein is recanalized, and a number of times these patients, also this portal cavernoma will compress on the bile duct, giving rise to what's called portal biliopathy. And these are the patients who have portal hypertension and jaundice, not an easy condition to treat. And I said earlier, extrahepatic portal venous obstruction patients are absolutely pristine normal livers. Now, what is non-cirrhotic portal fibrosis? This is a particular condition seen in the Gangetic belt, like you see in the carcinoma gallbladder, and mostly seen in Orissa, West Bengal. These patients, the etiology is not known. All the arsenic is one of the etiologies that have been made out. They have a condition called NCPF. In Japan, it's called non-cirrhotic idiopathic portal hypertension. They have normal portal vein. They have no cirrhosis. The liver is slightly enlarged. They have portal pressures high because there's periportal fibrosis. There's a fibrosis in the liver, in the periportal area. And strangely enough, these patients will have huge spleens. This particular condition is called nodular regenerative hyperplasia in the US, obliterative portal venopathy in France, idiopathic non-cirrhotic portal hypertension in Netherlands, and India, UK, US is called NCPF or NCPH, and idiopathic portal hypertension again in Spain and Japan, and also earlier in India. Hepatoportal sclerosis is what is called in Brazil and the United States. But this is how the cut section of the liver looks like. To the left, you see normal liver, normal portal venules. On the right, you see compressed portal venules because of periportal fibrosis. This condition is called non-cirrhotic portal fibrosis, and I'll be commenting on this from time to time. This is the histopathological feature is called phlebosclerosis with aberrant portal or periportal vasculature. This histopathology is very typical of non-cirrhotic portal fibrosis. And I said these patients have massive splenomegaly. If a patient with a portal hypertension, young chap in the 20s or 30s, comes with bleeding and massive splenomegaly, this patient is non-cirrhotic portal fibrosis unless otherwise proven. And then there's another condition leading on to portal hypertension, and that is due to liver outflow obstruction. See, as I said earlier, the blood will flow, gut blood will go through the portal vein into the venules and get filtered in the liver, and the filtered blood will get into the hepatic venules and hepatic veins eventually, which drain into the inferior vena cava. There's a condition where the hepatic veins can get blocked or that segment of IVC can get blocked, and that will put the pressure back on the liver. The liver will get slightly enlarged, and that will lead on to portal hypertension. And this portal hypertension, called post-hepatic portal hypertension, is also called Budd-Chiari syndrome, and this also called a non-cirrhotic sort of portal hypertension, but eventually these livers will go into secondary biliary cirrhosis. See, Budd-Chiari syndrome or hepatic venous outflow obstruction is where the veins alone can be obstructed, or the IVC alone can be obstructed, or a combination of these two can happen, which is classified into type 1, 2, and 3 Budd-Chiari syndrome. And this is not so commonly seen, but we have had reasonable experience in the all Indian medical sciences seeing these patients, and not very easy to treat. So 20% of the patients with non-cirrhotic portal fibrosis have some sort of a nodularity in the liver. They may have ascites. They may also have altered LFT, and this is called nodular NCPF. And it's been believed that this is a process of liver getting into cirrhosis. So there's one sub-segment of non-cirrhotic portal fibrosis who have nodular NCP with altered liver function. This is also one need to keep in mind. So how do you clinically assess and come to some conclusion whether a patient is come with a GI bleed is a cirrhotic, or a patient non-cirrhotic portal fibrosis, or extrahepatic obstruction? If the age group is 10 to 20, it's likely to be extrahepatic portal vein obstruction because they're seen in children. Cirrhosis is usually not seen in this age group. Their livers are normal, as I said earlier. Spleens are moderately enlarged. They're not massively enlarged like an NCPF. And their LFTs are normal. As far as NCPF is concerned, it's seen in second, third decade. Their livers are just enlarged because of congestion. And then they have massive spleens for some reason. And 20% of their LFTs are abnormal. And if you see hepatomegaly, massive splenomegaly, it's NCPF. In cirrhosis, strangely, the liver is shrunken, as you know, so the liver is not palpable. Age is above 40. They may have history of alcohol or history of jaundice, B or C virus. And now presently, you have non-alcoholic steatohepatitis, and their spleens are slightly enlarged. It's believed that whatever cirrhotic or fibrotic process that involves the liver will involve the spleen also. They do not have massive splenomegaly. Cirrhotics have non-palpable liver, shrunken, and also spleen is just about palpable, and the liver functions are abnormal. So basically, if you keep this chart in mind, it's not very difficult to clinically differentiate between cirrhotic patient, non-cirrhotic patients, and non-cirrhotic portal fibrosis and extrahepatic portal venous obstruction, because the treatment in these individual patients is different. Now, how do these patients present? Either they present in the emergency with hematemesis or melena, or both. How do you manage these patients? How do you manage these patients? I'll just touch upon the management of these patients. First and foremost, when they come to the emergency with bleeding, we need to stop the bleeding. Once you stop the bleeding, then you have to think of reducing the portal pressure. Actually, this happens mostly in the elective situations. Can I continue? And the third one is try find out the etiology whether cirrhosis, non-cirrhosis, and treat it accordingly. One of the age-old methods of getting hemostasis by endoscopic sclerotherapy, which is not used anymore. Now the present method is endoscopic variceal band ligation. These patients will be bleeding from the esophageal varices. The first foremost thing you do when a patient comes with upper GI bleeding is to find out by clinical examination and history whether it is a patient with portal hypertension bleeding or non-portal hypertension bleeding. If it is portal hypertension bleeding, we take a blood sample for grouping, cross-matching, liver function test to see whether cirrhotic, non-cirrhotic, and also we do complete hemogram to see whether any pancytopenia, and then look for coagulopathy. After that, we do an endoscopy to see where the patient is bleeding from, and based on an idea of etiology, we go apply rubber bands to the bleeding varices, and quite often that will control the acute episode of bleeding. Now, if the patient happens to be an extrahepatic portal venous obstruction, when the endotherapy, as I just mentioned, of either sclerotherapy or banding or a combination of the two, do not stop the bleeding. There's a phenomenon called TIPS, which I shall talk about later. That is there's a stent that is put through the liver, bridging the hepatic vein and portal vein. That is contraindicated except with portal vein obstruction because the portal vein is not available. It's thrombosed. In these patients with EHO, when they come with massive bleeding and couldn't be controlled endoscopically, if expertise available, they had to undergo what's called a splenorenal shunt, which is the most ideal procedure. I'll talk about it later. With emergency shunt, they have about 10% mortality and 10% rebleed and no encephalopathy because liver is normal. In centers where splenorenal shunt expertise is not available, a non-shunt procedure called Sugiura operation is done, where the esophageal gastric devascularization is done without esophageal stapling, and that has got a 4% favorable 4% operating mortality and 11% rebleed. In the patients with non-cirrhotic portal fibrosis who have slightly enlarged liver and a massive splenomegaly and severe hypersplenism, their bleeds are really massive. When they vomit quite often, they succumb to the vomiting. And these people tend to have good liver function, can withstand surgery well. TIPS is, again, not been practiced in this group of patients. If expertise is available, you have to do what's called emergency splenorenal shunt. As I said, the splenic vein is a part of the portal venous system. The pressure is very high. The renal vein is systemic vein, which pressure is anything to 0 to 4 millimeter. If you link high pressure splenic vein to the low pressure renal vein, the portal pressure will fall down, the varices will disappear. And this again has 10% operative mortality in an emergency setting, 10% rebleed, and 10% encephalopathy. This encephalopathy, as I told, because a certain percentage of patients with non-cirrhotic portal fibrosis have deranged liver function, they can develop encephalopathy. Of course, if you do devascularization, the rebleeds rates are higher in NCPF, and is anything up to, if you do modified Sugiura, it is up to 11%. Now, there is something called secondary prophylaxis in patients who come with upper GI bleeding in a non-cirrhotic patient. In EHO, one need to obliterate varices and decrease portal pressure. The obliteration of varices is done by endotherapy, and also the pressures are decreased by beta blockers, but endotherapy of the lower esophageal varices and beta blockers, they cannot correct gastric varices, which is seen in, especially when you do endotherapy for patients with portal hypertension, varices, lower esophagus, it will push the varices from the lower esophagus to the proximal stomach, which when gastric varices bleed, it is difficult to treat them. These people tend to have growth retardation. In this category of people, a definitive surgery is ideal, and that will decrease portal pressure for sure, and there's sudden growth spurt. Actually, Dr. Nandi's group has done more than, I think, 1,200 of these procedures. It's called proximal splenorenal shunt with a rebleed of 13%. And when these rebleeds occur, when you do an endoscopy, we again see varices forming, and they can be treated with endotherapy. In this EHO group, there's no encephalopathy, and they have a wonderful 95% 15-year survival. So secondary prophylactic operation is very ideal in this group of patients who are essentially children. And then when Sugiura operation is done in EHO, there's 11% rebleed. In non-cirrhotic portal fibrosis also, there's a role for beta blockers and endotherapy, but strangely, these endotherapy and beta blockers cannot control hypersplenism, which is seen up to 40% of patients with NCPF because of huge spleens. In them also, surgery is ideal, which will decrease portal pressure. The spleen is removed, and that will take care of pancytopenia. It's a one-time procedure. So if expert is available, one should take up for surgery. And in All Indian Medical Sciences series of 276 patients with NCPF who underwent proximal splenorenal shunt with splenectomy, the rebleed rate is 13%, and that rebleed was amenable to endotherapy. But there are certain group of patients that are subclinical encephalopathy, 30%. Those are the ones who have abnormal livers, and also a couple of nephropathy patients. Again, if NCPF patients are subjected to elective shunts, the Sugiura procedure, modified Sugiura, there's 88% 5-year survival. A word about surgery for portal hypertension. The surgery that is performed for portal hypertension can be considered as total shunts, selective shunts, partial shunts, and there is a group of non-shunt operations, and finally liver transplantation. See, these the pictures will show total shunts. An entire portal system is drained into the systemic venous system like a end-to-side portocaval shunt, side-to-side portocaval shunt, central splenorenal shunt, and interposition shunts. They prevent rebleed for more than 90%, but the huge encephalopathy rate of 40%. Orloff and group did this in large numbers, but their patient didn't die of rebleed, but they died of encephalopathy. It's not done anymore. Now is the time for selective shunts, and this is a procedure that is done to prevent variceal bleeding and also avoid encephalopathy. These shunts decompress the varices and also maintain portal perfusion. Selective shunts mean they selectively decompress the gastrosplenic compartment. They do not decompress the bowel compartment. This is what is called distal splenorenal shunt, where the spleen is still in position. The splenic vein is disconnected from the portal vein and it's anastomosed the renal vein, and this is a selective shunt which will gastrosplenic axis it will drain. Then there are partial shunts. There are shunts like mesocaval shunt, which have limited portal diversion and they maintain some liver perfusion. These are short, straight PTFE grafts. This is what is called a mesocaval shunt, where superior mesenteric vein and inferior vena cava are connected with a Gore-Tex graft or a Dacron graft. These grafts, for some reason, because it's a low pressure system, very quickly thrombose and patient may develop varices again. What are non-shunt operations? Non-shunt operations are esophageal transection, variceal ligation, and devascularization with without splenectomy, and they also have very limited role. These are done by surgeons who are not experienced in portal hypertension shunt surgery, but then this can be life-saving many a times. Here, you 2/3 of the greater curvature and half of lesser curvature plus lower end of all the vessels are completely disconnected with a pyloroplasty, and that to a great extent stops bleeding either in the emergency or elective setting. Now, I just want to show a few pictures of NCPF spleen. This is non-cirrhotic portal fibrosis spleen in a patient that operated, and that's a huge spleen. You can get such spleens only in chronic myeloid leukemia. When you have a spleen of this nature, portal hypertension, you'll be surprised to see the liver is normal. You expect to see a cirrhotic liver, but it's not true. Liver is normal. This is a classic patient of non-cirrhotic portal fibrosis. Liver normal, spleen is very huge. And usually the procedure involves first locating the splenic artery at the superior border of pancreas and tying the splenic artery in continuity. If that is done, the spleen will decompress, decongest, and it will large volume blood will go into the system. And after that, splenectomy is done. In these patients, you see the splenorenal ligament will be highly vascular, and if splenic artery is not tied, this is likely to bleed a lot. And this is where spleen is removed and splenorenal shunt is done. So, ladies and gentlemen, in summary, in patients whom we see with portal hypertension, we need to categorize them as cirrhotics or non-cirrhotics based on the clinical history, based on the clinical findings, and laboratory investigation and endoscopy. And if the patients are cirrhotic, surgery is almost obsolete. If these patients with cirrhosis come with acute variceal bleeding, we can consider a procedure called TIPS, or you have to have endotherapy and vasoactive drugs, with which some may respond, but majority do not. They have very, very high operating mortality if you do a shunt surgery, anything up to 77%. Now, secondary prophylaxis in cirrhotic patients who come with bleeding but stop, if the good livers, low MELD scores, especially child's A, you can consider selective shunt, but majority of them, child B, child C, would require TIPS as an emergency thing and as a bridge to liver transplant. Liver transplant is the treatment of choice. Whereas in non-cirrhotics, the two groups I mentioned, the extrahepatic portal venous obstruction and non-cirrhotic portal fibrosis, which these two categories are quite a number in India, surgery still has an important role. With the patients either with EHO or NCPF come with acute variceal bleeding, initially we try endotherapy, banding, sclerotherapy, and so on. If they do not respond to that, we should consider these patients for emergency shunt surgery. And the shunt surgery we follow is a proximal splenorenal shunt with removal of the spleen, because once you remove the spleen, the hypersplenism is taken care of, and the huge burden of dragging pain and a big mass in the abdomen is taken care of. In these patients, in the non-cirrhotics, namely EHO and NCPF, when they come with bleeding, but they stop bleeding, but they have to consider it for secondary prophylaxis, where an elective splenorenal shunt or in some cases devascularization should be taken up. And of course, presently, a lot of papers have come with minimal access approach, where through keyhole one can identify the splenic artery ligate and then try disconnect the splenic vein and stitch it to the renal vein. This is the future. Thank you so much for your attention. I'm done, Dr. Chetan.
Yeah. Thank you, Dr. Dr. Radhakrishnan. A very crisp, to the point presentation, elaborating the clinical presentation and how you distinguish between the cirrhotics and NCPH further into extrahepatic portal vein and NCPF. Very importantly, sir has shown how you, based on splenomegaly, the age of presentation, you can easily differentiate between the NCPF and the EHPVO. And what is the management in brief? His topic was how to approach. He has, however, dwelt in the management as well as what should be the ideal treatment. Actually, in clinical practice, what is happening with our endoscopist colleagues gaining expertise, we as a surgeons have a very minimal role to play compared to what it used to be in early 80s. Now, only less than 10% of patients land up for surgery. And mostly it is because of complication, as sir said, because either it is because of growth retardation or patient coming from a remote area where endoscopy is not easily available, or the lack of compliance. And so these are, and for symptomatic hypersplenism. So these are the indications usually which we operate for, or gastric varices, where repeated injections of blue injections have failed and patient is then referred for surgery. Are there any questions? Let me see the chat box. So one question is, yes. Hello.
Yeah, and Desai is
Dr. Desai, yeah.
commenting is any. malaria, Kala Azar, but malaria and Kala Azar do not lead to portal hypertension because they have huge spleens, but this hyperdynamic circulation in the spleen doesn't, I would say, translate into increased portal pressure. Portal pressure can only be increased when there is an obstruction in the portal venous system or in the liver or beyond the liver. In any of the veins, in the malaria, Kala Azar can be a differential diagnosis for a huge spleen, but not for portal hypertension. Dr. Chetan?
Yes. So, Dr. Desai has also asked that we are always taught that autosplenectomy occurs in sickle. So, how does it occur here? Dr. Radhakrishnan, your comment.
See, actually, autosplenectomy, I mean, I didn't understand that concept, but then the spleen has to be removed because otherwise, with the increased portal.
Yeah, so these patients have hypersplenism, symptomatic hypersplenism.
May I break in?
Yes, please, Dr.
It's taking
Desai.
too long
Yeah.
to type.
Yeah, Dr. Desai.
Basically, what you call opinion was given by one of the listeners that they see a lot of sickle cell anemia with huge splenomegaly that look exactly like this.
Right.
So, what we always were taught was that sickle cell anemia leads to autosplenectomy due to recurrent attacks, blockage, fibrosis, and the fibrosis contract, and the spleen comes down in size by the time they reach the age of 20 to 25.
Right.
And also, sickle cell anemia prevents malaria from occurring because the trophozoites cannot grow in the RBC because of deformation.
Right.
So, the gentleman from Tanzania, Dr. Kotecha, was saying they expected the same, but they're actually seeing only splenomegaly.
Right.
So that's how that discussion came up about.
Okay.
So, like you answered, Dr. Pattar, that if they have portal hypertension, they are NCPF. Otherwise, they are splenomegaly of any other cause. Am I right in getting that?
Yeah, true. I agree. Yeah.
Yes. Then there is a question from Senegal. So, doctor from Senegal says that is it advisable to perform liver surgery for HCC when there is mild portal hypertension and when transplantation is not possible?
Yeah. Mild portal hypertension can is not a contraindication for HCC. With proper techniques and all and equipment for dissection and coagulation, etc., hemostasis, we do perform surgery HCC resections in patients with mild portal hypertension. Severe portal hypertension, and that becomes difficult. Control of bleeding may be a problem.
So, in patients with portal hypertension, if you have to undertake liver resection, there are certain things which are very important. You have to see the liver stiffness. You have to measure the liver stiffness, and you have to see what is the severity of portal hypertension, clinically significant portal hypertension, what they say, CSPH. So if the liver stiffness is very high, then you expect that these patients will decompensate, and it is better not to do a liver resection in this and take them for transplantation. Similarly, if also very important is you have to see the bilirubin levels in these patients. What is the bilirubin? Because albumin bilirubin ratio is also a prognostic factor for the outcome following liver resections. So there are certain things which you have to take into consideration. But as sir rightly said, that if the patient is child A or early child B and you are not undertaking a major hepatic resection, you can definitely do liver resections for patient of HCC. Okay, so he now writes as what is the cutoff for liver stiffness? So basically, they say that anything more than 12 to 14 pressure levels more than 12 to 14 kilopascals is a danger sign, and you should not be doing liver resection in these patients.
There's a cirrhotic number.
That is cirrhotic. Any? Okay. Anybody else? Any other queries? Dr. Desai, you want to say something?
Not particularly.
Okay.
I could ask you your experience. How is it different in Mumbai, where you are?
Oh, so before the talk started, I was discussing with Dr. Radhakrishnan. We see a lot of portal hypertensions here. Basically, a lot of referred patients come here, and especially we see a lot of portal cavernoma cholangiopathy. We almost do about 3 to 4 shunts a month here, and they are mainly for PCC. And these patients have massive spleen, so we do a lot of proximal splenorenal shunt for these people. And we do, initially we used to do a lot of DVASC. I worked with Dr. SK Mathur extensively, and we used to do a lot of DVASC that time, but now the numbers have come down. We do about a one every 3 to 4 months. But we see a lot of portal hypertension patients.
Yeah. When you do your devascularization,
Yeah.
do you ligate the left gastric
Yes.
artery completely?
We always do that.
Yeah. So coronary vein and left gastric artery need to be ligated.
Yes.
Am I correct? Yeah, that's.
Yes.
Another thing I wanted to ask you was, when you do a devascularization, do you do a TANAS or do you do a classic devascularization as described by Sugiura?
No, we do a modified. We do a TANAS. What we do is that we always do a splenectomy because these patients usually have a large spleen, and then we ligate the left gastric vessels, and then we do a small gastrotomy, introduce a circular stapler, and just above the G junction we'll do a staple to this. Of late, in some patients who are referred for extensive gastric varices and in whom esophageal varices are not very significant, we may not do a transaction. But generally, we do esophageal transaction as well.
Yeah. So that has been my practice as well. We don't see as much as you do, but once or twice a year we will see such thing.
Dr. Patta, what about you? You do esophageal transaction always in case of DVASC?
No. Actually, I've had some very bad experiences with transaction, and that's the reason why as such, we do very few
Yeah.
DVASs. Because cirrhotics are very risky candidates.
Yeah.
Whatever you do, mortality is very high.
Right. So
Yeah.
patients who have undergone repeated banding or patients who have got glue injections, sometimes, the staples just gives away and there
Yeah.
is a disruption.
Because it's like a stone.
Yeah, it's stony hard. You have to just feel it to experience it. So in these patients, what we do is we underrun it rather than doing a transaction.
Yeah. There's
So that
also
is
a
how we
paper from
disrupt.
Dr. Chowdhury. There's also a paper from Dr. Chowdhury saying that in majority of patients where they have done endoscopic sclerotherapy for a long duration, the lower end of the esophagus is very friable and very
Exactly.
fibrous.
Yes.
So it's not possible to access the G junction.
Yes, and usually we use 29 number staplers, but in these patients we would electively use a smaller size, 25 for this, because as you rightly said, it's fibrous stenos, so it's very difficult. And the moment you go to dilated with sizer, it gives away.
What about strictures with portal hypertension in the esophagus?
So very common, again very common. So with due precautions, what we do is we ask our endoscopist colleagues to dilate it.
That doesn't induce the possibility for massive bleed. We have always been terrified of that.
Yeah, so it's basically with due precautions that
No, those things used to happen earlier days when sclerotherapy was used. Now sclerotherapy is rarely used. Actually, the bleeding from ulcer after sclerotherapy is a lot more difficult to treat than variceal bleed in itself.
And in sclerotherapy also, if you do the paravarizal technique of sclerotherapy, that used to give a lot of strictures. If you do intravarizal, then it doesn't happen.
Yeah. But lot of gastroenterologists, what they do is they band, and the remaining small tributaries which are left behind, they sclerose it. So
Yes.
you are left again in the deep blue sea. Devil on one side, deep blue sea on the other side.
Yeah, this is sadly none of these maneuvers will decrease the portal pressure. They shift the varices from the esophagus to the stomach. none of the endotherapy modules will decrease the only surgery can. When a vein to vein shunting is done, the pressures are down. Otherwise, the pressures don't go down.
So the principle of basically endotherapy in NCPH is that, especially EHPO, is that you keep on banding or sclerosing until they develop natural shunts over a period of time.
Right.
And that will take away the pressure.
Yeah. Some do, some don't.
Yeah.
What do you do for colorectal varices?
So
The treatment is the same.
Shunt.
Yes.
in
No,
these
but we
cases,
haven't done any for exclusive colorectal variceal bleeding. I don't remember doing any shunt procedure either in Delhi or in our practice. I don't know. Dr. Chetan might.
no, it is believed that generally for this, the mesocaval shunt will work better than a proximal splenorenal shunt.
There are a few people who say dissection would be probably an answer compared
But then
to
in that
not.
case, what
And
happens?
ligation of the inframesenteric vein.
No, but what happens is that over a period of time, they will develop elsewhere.
Yeah, true.
That will be difficult to manage.
Yes.
I know there are patients who have duodenal varices, and actually we had seen patients with stomal varices,
Stomal
which are
varices.
very,
Very
very difficult to
common. Yeah.
manage.
So I guess if there are no more questions, thanks a lot, Dr. Pattag Radhakrishnan. It was a really very nice talk on a very difficult topic, and you made it look very simple and very lucid and nice talk. Thank you very much once again.
Thank you, sir.
Thanks.
Thanks.
Thank you very much, Patta.
Okay,
Chetan
bye.
sir, thank you.
Thank you. Thank you, everybody, for joining in. Thanks a lot. Bye. Bye.